Welcome back. I'm the Intense MD, a double board certified intensivist, here to give you an inside look into the intensive care unit. If you didn't catch last week's video, it was all about code status and what that means. Today, I'm going to answer the 5 most common questions that I get when I'm discussing code status with a patient or their family. What's the difference between DNR, DNI, and comfort measures only? Sometimes people think that these things go hand in hand, and that's not necessarily true. If somebody opts for DNR, DNI, this simply means if their heart stops beating or their lungs stop breathing, they don't want us to do anything to intervene on that. They don't want to be put on life support. They don't want resuscitation. They want to die without any interventions or artificial means. Somebody can be on life support and opt for a do not resuscitate. Many times this will happen when somebody's placed on life support and we find that they are critically ill and we are unable to find a reversible cause. Many times the patient's family will opt to not resuscitate if their body continues to fail despite life support measures. Comfort measures only means that this patient or this patient's families do not want any machines or artificial means to keep the patient alive, and they want to opt to only focus on things that would make the patient comfortable. We stop drawing labs, we don't check vital signs, we only give medications that are aimed at comfort such as pain, anxiety, trouble breathing, things that would be uncomfortable if the patient's in crisis. So these are 2 separate decisions. If somebody wants to be DNR, DNI, they can still opt for treatment. If somebody only wants comfort measures, then that's a whole separate conversation than just do not resuscitate. Another question that I get asked that goes along with comfort measures only when we have the discussion of, well, there's DNR, DNI, and we continue to treat, and we have the comfort measures only option where we don't treat, we just focus on comfort. They say, wait, well, is the patient not going to be comfortable if we opt to treat and do DNR, DNI? No, we want our patients to be as comfortable as possible when they're in the hospital. Granted, being on life support is not a comfortable experience. We provide sedation, anti-anxiety medications, pain medications while somebody's actively ill. But this just means that our whole focus has changed to comfort and not treatment and comfort. Many people who have respiratory illness are concerned that if they opt for a do not intubate and do not want to be put on a ventilator when they go into respiratory distress, that they're going to die struggling to breathe. So I got asked, what are the options for somebody who's a do not intubate, who still needs support in terms of oxygen and to make their breathing more comfortable? So I already did a video about what the oxygen devices are in detail that are not the ventilator. But everything that's included in that video up until the vent is something that we would provide somebody who is a do not intubate, including a BiPAP or CPAP machine, which are considered non-invasive positive pressure ventilation. They are masks that cover typically the nose and mouth and provide a certain amount of pressure as well as oxygen to support the breathing. So the patient does not have a tube in their throat, they just have a mask over their face. This may support their breathing. We also have higher flow oxygen cannulas and oxygen devices. We also have high flow oxygen devices to support low oxygen levels. And if somebody is in respiratory crisis, we do have medications that we can give somebody so they don't have the sensation that we call air hunger. This is a sensation that somebody feels like they cannot get a breath and they feel like they're drowning. If they do not want to be placed on a ventilator and they are most likely dying of a respiratory illness or condition, we can provide these medicines so they don't feel like they're drowning in the last moments of their life. This is something many people are afraid of. There are options available to not have these uncomfortable sensations at the end of life. Who can help make this decision? A lot of times people have a lot of questions about their medical illness. They don't know what's appropriate for them, what's not appropriate for them. Many patients, for instance, with respiratory conditions, are concerned that if they go on a ventilator, they may not come off. So they don't want their last moments of life being on a machine. So a good place to start would be your primary care provider. This physician knows the most about you and your health. They know the full picture. If you have a condition such as end-stage heart failure, you might want to ask your cardiologist. If you have a severe respiratory condition like end-stage COPD, you might want to ask your pulmonologist. So the doctors who know you the best might be able to have a conversation with you about this so they can tell you what your chances are just based on their expertise of other patients they've cared for in the same situation. So a good place to start is your primary care physician, any subspecialist who has expertise in your specific disease process. Of course, many times if somebody becomes suddenly ill and they end up in the critical care unit, I'm the expert who is telling patients and their families based on my own experience of somebody who's required this amount of life support, who has a particular diagnosis, and knowing their whole medical history, what their chances are of different scenarios. Sometimes the doctors in the hospital are the ones who lead this discussion. When do I have to make a decision by? I get asked this a lot when I have a family meeting. I discuss all of the options of how we can proceed with treatment or no treatment. And I get asked, do we have to make a decision today? This is a big decision and it should not be rushed. I think the best time to think about this is before you even get sick, before you even get to the point you need hospitalization, intensive care. It's hard to think about when you're well, and many of us don't want to think about the possibility of us dying, but it's easier to think about these things when you are well and you have time to think about it and discuss it with other providers and those closest to you. It is a very personal decision. So like I said, it does take some time. And if you think about it this way, think of a time where you didn't feel well. Even if you just had a cold or, you had the flu, did you want to make any big decisions? Did you even want to think about what you were going to have for dinner? No. So when you're critically ill in the ICU, are you going to want to make these big decisions about your treatment and end of life goal? If somebody comes to the hospital and does not have any prior discussion about code status, if they don't know what they want, our default is to do full code. Our default is to continue doing things in an attempt to resuscitate and save this person's life, including emergent procedures, life support, emergency medications. So up until the point that somebody dies, that's the amount of time they have to make these decisions. Nobody can predict exactly when that's going to happen. So that's the amount of time somebody has. Of course, in the intensive care unit, when somebody actively ill, we do tell families it's a little bit more time sensitive, but you have up until a certain point to discuss amongst each other. And of course, if the patient shows signs of getting worse, then we reach out to the family and say, hey, we've had this discussion before. It looks like they're progressing. Did you guys have time to think about what you would want in this situation? We don't want families to feel rushed, but we also want them to know what the situation is, what the chances are of this patient having their heart stop, so we know whether or not they want CPR and resuscitation. And it's my job to tell them from my expertise what the chances of CPR being successful is, because there are different scenarios where CPR may or may not work. A lot of times people don't want us pushing on their chest at the end of life. Many people ask if their loved one is on life support and they opt for comfort-only measures, what happens? So we give the patient's family time to visit with the patient. We tell them, when everyone feels they've had the opportunity to say goodbye and visit with the patient, then we'll proceed with the comfort measures only. If they're on the ventilator, we take the breathing tube out and we place oxygen on the patient, and we turn off all life-sustaining drips. We watch the patients closely to see if they have any signs of distress, if they look like they're anxious, if they look like they're in pain, then we treat those symptoms. Many times before we take the patient off the ventilator, we'll give them some medication to ease their breathing. So especially if they're on the ventilator for a severe respiratory illness, we don't want them to start gasping for breath as soon as we take them off life support. So we do give them medications to ease their breathing so they don't have that sensation. And in terms of the amount of time it takes for the patient to pass away, that is a case-by-case basis. I can usually tell families if I think it's going to happen after several minutes, maybe a couple hours, or if I think they might last a couple days. Usually we're pretty good at predicting if it's going to be minutes, hours, or days. Many people in the intensive care unit, it's usually minutes or hours, not necessarily days. So these are the 5 most common questions that I'm asked in the ICU when I'm discussing code status with patients and their families. If you have any additional questions about this topic, please leave them below. I can make a follow-up video to answer even more questions because this is a very complex topic. I'll see you on Friday for the next video.